Good morning, good afternoon, and good evening, and welcome to our webinar on designing a contraceptive self-injection program, experience from Uganda. Let me begin by introducing today's speakers. I'm Jennifer Drake, and I'll be moderating today's webinar. I'll be giving some background on the injectable contraceptive subcutaneous Dmpa, or Cyanopress, as well as past new self-injection best practices project in Uganda. Alan Namagembe, our research and evaluation lead in Uganda, will be talking about the self-injection program design process we've been undertaking, as well as initial results from a rapid pilot. And finally, our research officer here in Seattle, newly returned from Uganda, Ellen McLaughlin, will be talking about implications for self-injection program design and next steps. Just a reminder that if you have questions, we encourage you to send them through the chat feature on your computer, and we hope to address as many of them as possible at the end of the webinar after the presentation is done. So subcutaneous Dmpa is a new progestin-only injectable contraceptive product shown here. Cyanopress, manufactured by Pfizer, is the subcutaneous Dmpa product most widely available today. This slide helps explain what makes subcutaneous Dmpa different than the already widely used intramuscular Dmpa injectable, which is also known as Depo-Provera, also produced by Pfizer, but also available in generic form. Subcutaneous Dmpa comes in a pre-filled, all-in-one injection system called BD Uniject, whereas intramuscular Dmpa comes in a vial with a separate syringe. Subcutaneous Dmpa is injected in the fat just under the skin, or the subcutaneous fat, where intramuscular Dmpa is injected into deep muscle. Subcutaneous Dmpa has a lower dose of the drug and also a shorter needle. Both products are safe and highly effective at preventing unintended pregnancy for 3 months when delivered on time and correctly. The methods don't protect against HIV or other sexually transmitted infections. They're comparable in regards to side effects, and they're both stable at room temperature. The unique features of subcutaneous Dmpa presented on the previous slide present opportunities to bring injectable contraception closer to where women live through community-based distribution, provision at pharmacies and accredited drug shops, and even through self-injection. In turn, these service delivery opportunities can expand access, increase method choice, and empower contraceptive users. The currently available subcutaneous Dmpa product, Cyanopress, has been approved by regulatory authorities in more than 25 countries, including the European Union. Increasingly, it's also being registered for self-injection. This includes registration in the United Kingdom, several European countries, and an increasing number of Family Planning 2020 countries, including Uganda. Thanks to a new price reduction that was announced just a few weeks ago, Cyanopress can be purchased at 85 cents per dose by qualified public sector buyers, like ministries of health in FP 2020 countries and agencies like UNFPA or USAID. Next. In Uganda, the Ministry of Health, PATH, and partners trained more than 2,000 community health workers to administer subcutaneous Dmpa beginning in 2014. Between 2014 and mid-2016, more than 130,000 doses were administered by those community health workers through the pilot. A national scale-up is now in process. A number of activities specifically focused on self-injection of subcutaneous Dmpa have also taken place in Uganda in recent years. A past Ministry of Health feasibility study found that nearly 90% of participants could self-inject successfully 3 months after one-on-one training. Nearly all of these women wanted to continue self-injection. Based on these findings, self-injection was rolled out in late 2016 in public facilities through a soft launch in one district, Mubende, with Ministry of Health approval. Self-injection was approved by the Uganda National Drug Authority, or the NDA, in early 2017 and will roll out in additional districts later this year. Building on all those activities, a new project launched in Uganda at the beginning of this year, known as the Self-Injection Best Practices Project. This project was designed in response to a recognized need to understand how self-injection delivery will work in the real world in diverse contexts and circumstances. This is the basic framework of the project. PATH will identify components and models of self-injection programs and then implement and evaluate them in order to help identify best practices. In this project, there is a strong emphasis on dissemination. We will share what we are learning as we go to help implementers and decision makers considering or offering self-injection in other places. Another key element of this project is user-centered design. User-centered design focuses on the users, not what the designers, researchers, or their bosses want or think users need. Both observing what users do and listening to what they say are critical for user-centered design. A user-centered design process is also iterative. I will now turn it over to Alan Namagembe, who will describe how a self-injection program in Uganda is being repeatedly tested and refined through an iterative process.
Thank you, Jen. So Jen has already mentioned that the feasibility study was completed and informed a soft launch in late 2016. Both these experiences focused on offering self-injection through the public sector facilities. I'm going to talk now about how we are continuing to iterate on the program design for public sector facilities through some user-centered techniques, which will include the journey map, feedback workshops, and the rapid pilots. Next slide, please. So some of the learnings from the feasibility study were one-on-one self-injection training took over an hour, and the practice costs were more than $1 per client. Also, clients relied so much on a booklet, instruction booklet, which brought the cost to about $2 per client. And latrine disposal, although was common during the study amongst women who participated in this study, it was not appealing to stakeholders. And really to focus on our follow-up, just 38% of the self-injection clients in Uganda have cell phones. Next slide. So some learnings from the soft launch. Next slide. Some providers are too busy to train clients to self-inject, and providing a disposal container to each client may improve safety. And also, the other learning is instruction booklets may not be sustainable. So the thinking is to have a shorter instruction sheet, maybe a one-pager. Next slide. So how did we go through this, developing the journey maps for self-injection programs? Based on the research studies and the soft launch, we designed program components with our best guess models. We identified program components likely to impact client success given the lessons learned from our previous programs, developed journey maps, and these are what this is really a walk through the client and provider experiences in a self-injection program, as well as considering specifics to clients under the ages 15 and above, right, to maybe adolescents. Next slide shows the Ugandan team really developing the journey maps, which are the user-centered frameworks that help designers understand clients and provide experiences, perspectives, and needs by walking through every step of a program. On your left is a journey map for community-based distribution, commonly known as village health teams or VHTs in Uganda, and maybe just in the right section, the commercial sector. Next slide. This is what a journey map looks like, but we're not going to go into the details of this. But in this sample journey map, really providers are conducting group training of women who are interested in self-injecting, and they're observing the woman injecting with coaching, meaning the woman does not practice before she injects herself, and she's using a one-page instruction sheet, and she's also instructed to return the used unit or device to a health worker at her earliest convenience for proper disposal. Next slide. So what did we learn when we were developing journey maps? Stages of client training, from orienting clients to contraception options to a first self-injection, are kind of vary. Then how the group training could work in a facility. That is how the clients flow in, how they wait for the providers, and also the human resource requirements, given that for most of our health providers, we have constraints. Also, in considerations were supplies needed for client training and for clients to take home. That is, if they are to train the water-filled device, then how many units they would want to take home. Then safely also transferring used devices from a puncture-proof container to a health worker for proper disposal. Additional systems required, e.g. orienting other providers on what to do if a self-injector returns for support or they return the used device. Next slide. So for the user-centered design feedback workshop on self-injection program design, one, we organized these, next slide please. We organized these to solicit input from the different stakeholders in the following order. Next slide, yeah. So we interacted with clients, and these included those with and without self-injection experience, facility-based providers, including those with and without experience offering self-injection, and because there's already a soft launch delivering self-injection outside the research setting, we had a chance to interact with those who had already been providing self-injection at their facilities. Also community health workers and stakeholders, including district health leaders, the Ministry of Health, as well as other implementing partners. During the feedback meeting, we used role plays to illustrate the self-injection journey map, making it a real kind of tangible experience for the clients and the providers. We involved the clients themselves and providers to act as the different players in the journey map. Then we adapted the client booklet into a one-page job aid to share and vet during the feedback meeting. And after the role plays, we really solicited feedback from both the actors and the observers using semi-structured feedback meeting guides. Next slide. So for the feedback workshop, group training, maybe those are some of the learnings we really got from there. our group training may be more feasible than the one-on-one, given the workload of the health workers. Then self-injection without practicing may be possible and acceptable, and this was also coming through the Ministry of Health respondents, although clients were more nervous about this idea of injecting without practicing. Majority of the participants said that VHTs conducting the training would ease up on the health workers' workload. Then ensure there is a dedicated health worker clearly identified as the self-injection trainer. This means there's someone who will be doing that at all times. Then follow-up should be client-driven. That is, some clients would prefer to initiate follow-up by contacting providers only if they need it, not have providers following them up even when they don't need the support. The other alternative was peer follow-up, and this included, they were discussing assigning successful early adopters, assigning them 5 to 10 peers to follow up. And these should be people who have re-injection around the same time. And then for the number of units to be given to take home, the district health leadership proposed 1 for a start and 3 thereafter. But clients felt they could take 3 units right away as soon as they are trained to self-inject, and they've done it successfully. One other note was health facilities have poor waste disposal practice, and as we learn, this might not only be a challenge for self-injection, but it's a challenge for the entire health system in Uganda. From the feedback meetings, we had to revise our journey maps, which we are implementing in the rapid pilot. So next slide, I'm going to talk about the rapid pilot and how we implemented it. So the objective is to assess what works best with our local staff, the local providers, making adjustments to programs, and this will take about 2 to 3 months, and there will be intensive monitoring and engaging both the providers and the clients. So this is going to give us an opportunity to iterate program procedures and learn before full implementation and evaluation of the program, which will begin in quarter 3. So in the rapid pilot, we trained health workers from 3 health facilities in the district of Mubende. And these 3 were community health workers or nursing assistants, and 4 were nurse midwives who are really keen on providing family planning services at these facilities. And just to mention that 3 of these health workers had never been trained to deliver subcutaneous Dmpa, even if we are implementing it in a district where we've already been implementing this. So we are closely monitoring the site every 2 months and iterating components as often as feasible based on input from the providers and clients, and this is being documented. 2 weeks. Thank you. So in the next slide, this is an example. It's a simplified journey map. Next slide, please. This is a simplified journey map for the health workers involved in the rapid pilot. We are changing things incrementally from the original approach used in our feasibility study and the soft launch. So for the rapid pilot, for phase 1, this is the beginning. We have initially trained community health workers and nursing assistants to offer self-injection training through groups, and include clients to be able, they can practice in the group. Then after the practice, they are sent to a nurse midwife who supervises the first self-injection. And also, reviews if she's really she has comprehended what she's been taught, and then gives her the supplies to take home. Next slide. This is another simplified journey map, and this is at phase 3. So over the course of the rapid pilot, we'll adjust different approaches and follow up with providers and clients to see how things go. In the phase 3, for example, the community health worker or nursing assistant will do the entire training of the women. And then they will also supervise the first injection. So it means at this phase, the nurse or midwife will not be involved at all. Also at this phase, clients will not practice. Instead,
hi, Alan. So sorry, I think we lost audio there. So I'm going to ask Ellen McLaughlin to pick up on the phase 3 overview of the journey map, and hopefully we'll have Alan back during the Q&A section.
So like Alan was saying, this is an example of some of the different program components that we're trying out during the pilot phase, and including changing the disposal, for example, at the end is burning the unit and seeing how that works. And then instead of having 2 different providers supervising the injection, having the entire process. If you see under the yellow bubble, having the entire process supervised by VHT or nursing assistant. Next slide. So we've just started this pilot in May. So these are really recent learnings. For example, we're finding that even if we want to separate some of the activities, some of the procedures between different cadres, variations in staffing levels, which I'm sure all of you are familiar with, at facilities really impact our ability to separate procedures for different cadres. At the facilities we visited, which we did just in the last 2 weeks, for our first monitoring visit, we found that most facilities have twice-a-week family planning days. These actually really facilitated group trainings because large groups of women were available for self-injection trainings, and then a higher level cadre like the midwife would supervise the individual women who went on to self-injection. Like Alan was saying, based on how well the facility was implementing the different program components, we decided which ones were ready to try a new component or not. So one facility had enrolled many women on self-injection, and so we moved them to a new phase so we could try out a new variation of program components. Many women do participate in the group trainings but decide not to self-inject until later. They just are too afraid to inject. Many of them, the provider will go ahead and inject them, and many of them decide that they'll come back at the 3-month re-injection time point and try self-injection at that time. So that seemed to be pretty common. So I'll just continue a little bit with how we're using all these learnings for program design and next steps in our program in Uganda. We've talked a lot about the training. It's an essential component of the program, how to train and support women to self-inject. And as Alan has said, we're learning a lot about group training. We have a lot of experience with one-on-one training from research and programs in self-injection already in Uganda. We have less experience with group training and which different catters can support group training, and of course, does it support proficient self-injection by the women. We've learned that the injection steps, reviewing the injection steps, whether it's during the group training or during one-on-one supervision of the actual self-injection by women. But reviewing the steps is critical for women to be able to self-inject independently. So this one page that you see on the this one-page instruction sheet that you see on this slide is a really critical tool at this training phase in the programs. We're also learning during this pilot, it may be possible for women to learn self-injection steps without actually practicing. So meaning using a water-filled unit to try injecting. We've been using a condom filled with salt for women to use to try injecting while following the instruction sheet. But it may be possible for a healthcare provider to demonstrate the steps, walk through the steps with women in a group, and have women self-inject after that demonstration in front of the group. Next slide. So we aren't very far along in the pilot, so we haven't been able to test out a lot of different ways for follow-up with women. But definitely, like I just said, we have this instruction sheet that women are given when they initiate self-injection, and that visual aid is an important part of follow-up for women to be able to independently self-inject. We'll learn more about women's preferences for follow-up. They want a VHT, this community health worker, to visit or call them or get in touch with them somehow for reminders for self-injection or to help them manage side effects. Or would they rather just initiate that kind of contact themselves? Maybe there are women who don't want to get follow-up from a village health team. And we're thinking about also a hotline where women, especially if they're experiencing side effects and helping side effects management, would that be something feasible for helping with follow-up? So follow-up is both reminders for re-injection, but also helping with side effects and any questions or problems they're having with self-injection. And finally, thinking about whether SMS or mobile platform could work well in settings where women have, if they have access to phones. Next slide. So another component, really critical component, is the disposal. So we'll be watching that really closely and trying out different variations on disposal. Latrines can be used. They're used by a lot of women and communities for getting rid of waste, and it's preferred by clients, but it's not perceived to be really sustainable or safe over the longer term. Extra focus is needed during training, so we have right now puncture-proof containers that are supplied to women during the trainings, and if they self-inject, the providers watch them put the used unit into a container, and explaining the need to always do that when they're self-injecting so that the unit is in a puncture-proof container, whether they take that container to a VHT, for example, or return it to a facility. That's one thing we'll be testing. Different ways where they can bring that once they have used units. Like I said on one of the variation slides we will try out burning the unit along with household garbage, which is a common waste practice in a lot of these communities. So a lot of our emphasis in Uganda is on the public sector, and after this pilot, we'll be finalizing program designs for the public sector. Actually, we'll be finalizing components of a program design that will then be varied as part of our evaluation design. And the public sector will train 60 to 100 providers in more districts. So we're currently working in one district. We'll expand to 3 districts, and then test, some of our final program variations in these facilities across the 3 districts. We'll be using the same design process, the user-centered design, to also start programs in the private sector, community-based distribution by the village health teams in Uganda, and also an adolescent-focused platform. And in each of these programs, we'll be using, looking at the same critical components of training and follow-up, making sure adolescents and women have adequate support, and then, of course, disposal of the waste as well. So we'll be collecting evaluation data and looking for best practice in each of those channels. So finally, we'll be evaluating these programs carefully, especially to determine self-injection proficiency using different program components. So from evaluation perspective, this list here, some of our most critical outcomes that we'll be looking at. How can we reduce costs while still ensuring that women are successful with self-injection? That will be really important to try to develop programs that are sustainable, can be implemented in many different settings. Accessibility, for example, of course, to adolescents, but also rural women, different hard-to-reach groups. We'll look at user satisfaction and adequacy of support, especially for follow-up, but also training support and materials women need. Provider practice, making sure provider practice, these programs fit well within the health system or within the private sector, in a sustainable way, and also just provider perspectives and perceived feasibility. Is this a program that could be implemented over longer term? Are they satisfied with the program? Does it fit well into their practice? And implementers who want to try out these programs don't need to wait for us to, for evaluation results. The PATH team is learning as we go, and we plan to maintain real-time program design resources that and also be available for consultation if any implementers have questions. So this, I think you can tell from our presentation, this is an ongoing process, and we're learning every step of the way. So we welcome your questions. We have, quite a bit of time for Q&A now. So please, let's start with the question and answer period.
Great. Thank you so much, Ellen and Alan. And just one quick bit of information I'm realizing we did not share is that we'll begin the training of all of these different providers in these various program designs towards the end of this year, late Q3 and Q4. And the evaluation will run through much of the beginning of 2018, and we'll have full results towards the end of 2018. So that's the general time frame of this project. Great. So we have some questions coming in. First question I'm just going to take quickly. And somebody wanted to have a little bit more information about the soft launch in Uganda. So let me just clarify that. The soft launch rolled out in, I believe it was late October, early November of 2016 in Mubende district. And PATH worked with the district health team to train about 100 providers in facilities of Mubende. The approach to the soft launch was relatively close to the approach that we used in our feasibility research study because it was the first program offering, and so we really wanted to do what we knew worked as we began to offer self-injection to women in Uganda. So for example, those providers in late 2016 did all of the training one-on-one. They used client booklets. Every woman had the opportunity to practice. And so all of those components, the format of training, the booklet versus the job aid, whether women practice or whether they observe a demonstration and then get coaching and supervision for their injection, are being now varied and assessed through this new project. Great. So I'm going to take the next question we'll try Alan. I think she may be back on. Alan, are you there?
No.
No. Okay, too bad. Alan has a lot of experience to share, but hopefully another time. So Ellen, can you talk about this is a really interesting question coming through. What elements of this design process would you say would be worth repeating in other countries that want to introduce self-injection? What recommendations do we have at this point for how somebody might go ahead and work on that?
Yeah, I think there's ways to use this same process. You may not do an identical implementation, but I think, of course, the best practice is always a research review. PATH has a lot of experience now with self-injection, and we've published articles and different, resources about it. So I think that always, a review of what's known already is critical before starting a project. The second step of feedback meetings. Once you have an idea of maybe some program components, I think always with program design, getting input from the actual providers and users is a best practice as well. The rapid pilot, I think some sort of phase-in of, especially in a place where there hasn't been self-injection. I mean, I don't know if it needs to be as structured as our rapid pilot is, but I think it's really important to have some sort of phased-in approach to make sure your program components are really going to work in a real setting in health facilities and with providers. So I think those three pieces of how we've prepared for the programs would be really important in any country.
Great. Thanks, Ellen. And just to add quickly about the journey maps, when we were first working on those journey maps with the Uganda team, we had a lot more questions than answers in some cases about how exactly this program would work, because we realized it was the first self-injection program that we knew of in sub-Saharan Africa outside of a research context. So a lot of things were speculation, and I think the journey map exercise itself is a really useful one for any context because it helps you think through how your system actually works. But hopefully it'll actually become easier to adapt and move quickly with a journey map in more settings now that we're building up an evidence base on exactly how this works in Uganda and hopefully other places soon. Great. So we have a number of questions about waste disposal, so I want to make sure and address a couple of those. So number one, what have we heard, if anything, about whether waste disposal is a discretion issue for women, and if it's come up in the context of women wanting to keep the waste a secret? And then a second question on waste disposal is just a little bit of information about the cost of the puncture-proof containers and how we figure that into our program design. And then finally, the environmental impact of burning at home, potentially. So any thoughts on that, Ellen?
It definitely is a discretion issue for women. One of the appealing thing about, a latrine for women is they can just throw it away and it's gone, and, nobody can get to it, nobody's going to see it. So it's not as appealing to women to have a container with used devices in it that they have to, keep away from children, or keep, if their husband is not aware of their family planning use, they wouldn't want their spouse to find out. So they are interested in more discreet ways of disposal. But they also, the VHTs, most women know their VHTs, they live in the same village, they're both in the same community. They also have a lot of trust for their VHTs, and so we're pretty hopeful that that's going to be one way. If they aren't using a latrine, or they don't want it, if they have the container in their house and they don't want it there, they can get it to their VHT, who can take it from them.
Great. Thank you, Ellen. Alan, just checking to see if you're back, because I know that you've done a lot of thinking and working on this waste disposal issue in Uganda as well. No? Okay. Thanks, Ellen. Great. So another question that we have, which I'll answer really quickly, is whether subcutaneous Dmpa, or cyanopress, was introduced in Uganda across sectors. So, for example, in social marketing or the private sector at the same time as the public sector. In Uganda, the product was only introduced initially in the public sector through community health workers. In 2016, PATH and other partners began working with the Ministry of Health to also offer the product at some facilities in the public sector as well. So up until now, it has not been available in the private sector. However, the group, the Uganda Health Marketing Group, as sorry about that echo, both are actually on the brink of launching a social marketing private sector offering of this product in Uganda. So it'll be really interesting to see, irrespective of self-injection, how the new offer of cyanopress or subcutaneous Dmpa in the private sector affects the market in that country. The initial offering will be, I believe, through provider administration only, but we will be slowly looking at how self-injection might be integrated in that. Great. So another question, Ellen, can you talk a little bit about how clients find out about self-injection, how they assess whether they're eligible, how providers are trained to assess whether clients are eligible for self-injection?
Mm-hmm. Yeah, in my experience, they, a lot of it is, and again, we haven't been implementing outside of research for very long, but the word of mouth is, for all family planning products, is one way that women they find out about it from a friend or somebody who's just been to the facility. The VHTs have a really important role with letting women know about self-injection. A woman who's been counseled on different family planning methods and is interested in an injectable will find out about cyanopress through a VHT. And then a lot of VHTs now, as we've said, have been trained in self-injection, and at that time would let women know about self-injection services at a facility. So I think those are the two main ways. Over time, I think this could have a little bit more sophisticated, advertisement type program. But right now, it's that the women are already interested in injectables, and I think word of mouth and the VHTs are working pretty well to let women know about services.
Great, thanks. And how are providers trained to recognize contraindications for use of the product, just in general?
For Depot?
Mm-hmm.
Yeah, so there was a general family planning training, including injectables and side effects of injectables. So, you know, the same goes, the same exact training is used for self-injection, that make sure that the different providers, whether they're VHTs all the way up to, you know, more a midwife level provider, knows about contraindications and talk to women about that. Again, now in this setting, we're talking about those. They may have been mentioned in a group training, but we're relying on providers during one-on-one supervision to go over those kind of contraindications and make sure it's the right, you know, it's still the right method for women to choose. So just like any family planning method, the providers once they're supervising women one-on-one, they would, you know, identify any problems like that that should be addressed, that would limit women from using, you know, injectables or DMPA.
Great. Thanks, Ellen. I'm seeing a lot of questions about costs, so I'm just going to give a quick overview of what we know about costs, what we will know about costs eventually, in some cases sooner than later. So right now, PATH is in the process of wrapping up a few studies comparing the costs of subcutaneous Dmpa from providers in Burkina Faso and in Uganda. And in Uganda, those providers are community-based health workers, or VHTs. So those results on the cost of those programs, which include training health workers on subcutaneous Dmpa injections, will be available in a couple of months. There's a similar study in Uganda comparing self-injection with DMPA-IM, or intramuscular DMPA, from providers, and those results will also be available later this year. So we'll have a little bit more information about how much it costs to offer self-injection. However, in those studies, and in particular the self-injection study, the provider is again implementing this approach of one-on-one training and at a facility with a relatively higher level provider like a nurse or a midwife. So over the course of this project, we will be, as part of the evaluation, as Ellen mentioned, gathering information on costs for different approaches, and we'll have more information on costs in 2018. Anything to add about costs, Ellen, from your perspective?
No.
Okay, great. So Ellen, coming back to what we were talking about earlier in terms of what steps other countries would need to repeat, there's an interesting question here.
Okay.
Whether Senegal needs to run a pilot program or whether it could implement the program based on the stability study of self-injection. So there was a similar study in Senegal to the one that we described for Uganda, as well as these experiences from Uganda. So what's our sense about Senegal or other countries needing to do pilots versus kind of take the evidence and roll out this intervention?
You know, so we're doing the same thing. In Uganda, you know, the PATH team there is going from, you know, research setting to implementing this in the public sector with, you know, within the health system. And, you know, it's different. So different issues come up, and some approaches are feasible and some aren't. So well, I wouldn't call it a pilot, but some sort of, it's a new way of providing family planning to women, and I think some sort of phase-in is needed to determine whether, you know, even if something's been shown feasible in a research setting or even evaluation setting, some sort of phase-in in a health system is needed to determine whether those program components are really going to work in the health system. So I don't know if a pilot, a rigorously evaluated pilot is always needed, but some sort of phase-in just to determine whether it's going to work for clients, whether it's going to work for providers, or maybe if it's in the pharmacies or in the private sector, if really all those different program approaches are feasible. I think that's a smart step before starting a large expansion of these kind of services.
Great, thanks. And it also, I think, comes back to the points about user-centered design that we were making towards the beginning, which is one key element of user-centered design is not just asking people what they say, but actually observing what people do. And there's really no way to do that without just trying, which I think argues for this idea of phasing, even if it's not technically a rigorously evaluated pilot effort. So I just want to mention Alan is coming in and off the internet, and she did send a comment that the price of the containers that are given to women for disposal, so those little Vaseline type containers, the tip-top containers that were shown on the slides, are about 20 cents per person. They were purchased in bulk and distributed. So that will be included when we do our costing evaluation, and we'll see, how it contributes to the total cost of the intervention. I think it will be very interesting to see how something like that works in the private sector, where women have to purchase their unit and potentially any other supplies that would go along with self-injection. Ellen, can you talk a little bit about how any data that PATH is collecting through the self-injection pilot is being linked or not with the health management and information system in Uganda?
So far it's not linked. In some of the facilities, they are noting whether women have chosen cyanopress versus intramuscular Dmpa. But that's just at the facility records. I don't think that distinction is now, that's not currently in the HMIS. That's one of the goals for sure, is to increase, as subcutaneous Dmpa use widens, to make sure that both the use of subcutaneous Dmpa plus self-injection is captured better in HMIS. I think that's an important, to make sure countries are tracking that kind of information will be really, really critical. Actually, so any ideas on how to go about that and how to increase it is welcomed. So far, that hasn't happened yet, but it's definitely one of the longer-term goals in Uganda.
Great, thank you. And we have a question about how PATH is addressing potential risks related to HIV acquisition and DMPA. So I'm going to speak to that briefly. Basically, PATH introduces any offering like this through and in collaboration with the Ministry of Health. So PATH does not implement its own service delivery, for example, in parallel with the Ministry of Health or public sector system. We work in accordance with Ministry of Health guidelines and policies. And so at present time, we are continuing to support the offer of services in alignment with MOH policies and guidelines, which have not been updated or changed since the March update from the World Health Organization on progestin-only injectables and HIV acquisition. It wouldn't be appropriate for PATH independently to go out into communities of Uganda and begin talking with providers and women about this independently without support and collaboration with the ministry and the district health team. So what PATH is doing is working very closely with the ministry to sort through how it's going to address these new guidelines. And our hope is that towards the fall, when we will be training providers to actually roll the self-injection program out, we will have had the opportunity to clarify the position of the Ministry of Health and other partners in Uganda who offer these types of family planning and contraceptive services. But we continue to emphasize very clearly for women in all of the provider training that it's incredibly important that women understand that this method will not protect them from HIV, and if they have any concern about HIV risk, that they need to use male or female condoms to protect themselves. Another question, Ellen, that we have, I think we have time for maybe one or two before we finish. Can you say anything about, I don't know if in your recent trip you talked to any providers about this or saw this, but what can providers do with regards to addressing fears of self-injection? Was one of the questions from a webinar participant.
Oh, that's interesting.
Yeah.
You know, the longer, one thing that Alan and I, it's too bad Alan's not on.
Yeah.
But Alan and I both noticed is, and you know, this is true for lots of programs, different providers have different levels of comfort talking to women and encouraging women and training women. And some of them are just better at it than others. So, you know, we talked to a provider that had 20 years of family planning experience. She's an older woman. She's very passionate about her work. You could tell. And she was very good at talking to women about self-injection, about, you know, the steps needed and the follow-up needed. And we weren't surprised to see that she had a lot of women who had accepted self-inject and had helped them overcome their fears. And in other cases, you know, there was a younger provider, probably had only been at the site for a year, had just graduated before that, and fewer women under her, you know, with her training had accepted self-injection. So I think provider characteristics will make a difference in overcoming those fears. It does take some time. You know, I think the group training and, you know, the support from their peers and then the support from the providers, you know, the more time they have to talk about it with the provider, to talk to, you know, their peers about it, I think will make a difference in overcoming fear. The more people, the more women that start self-injecting, the more, just like with any behavior, the more women hear that somebody is successfully self-injected, I think the more women will start to come over their fears. Right now, it's fairly new, and they don't run into as many women who've done it already. That'll make a difference too, as it becomes more commonplace.
Great. Thanks, Ellen. And I think I'm going to close by just reinforcing that, you know, I think the other point that this question helps raise is the importance of informed choice, and that, you know, self-injection is one option among many, and that if a woman is afraid to try self-injection, then that may not be the best contraceptive option for her. And that relates to the issue about HIV as well, that this program and any program that we work on in Uganda or any other country is always implemented under the principles of free and informed choice and voluntary use of contraception. And so that is also emphasized in all provider trainings that occur. So self-injection is really exciting. I think it has a lot of potential to open up access for women, but it's not going to be the best choice for everybody. And with that, I think we will close today's webinar. So thank you very much, everyone, for your participation and your great questions.